So welcome everyone to today's Lunch and Learn. We've got with us today Tom Crocker, who's the Associate Professor of Stroke Care, and he works in the ARC Older People's team. And Tom's going to be going through today about grade in relation to systematic reviewing. Tom's got some slides that he'll share. I'll keep an eye on the chat. And if everyone can put themselves on mute, that would be fantastic while the presentation is going on. And there'll be opportunities for questions at the end. And obviously, like I said, I'll keep an eye on the chat. I've also put a link to our ARC newsletter website and YouTube channel in the chat because this will be recorded and put on our YouTube channel by the end of the week. So I'll pass over to Tom now. Thank you.
Thank you very much. Let me just share my slides. Hopefully you can see those. And yeah, so hi everyone, I'm Tom Crocker. I'm presenting about grade in relation to systematic reviews of intervention effectiveness. So often when people do systematic reviews, they present the results of a statistical analysis, a meta-analysis, and that's kind of as far as the findings go. And I think that grade's really useful because it's a way of us looking at the certainty of those findings. How much confidence can we have in them? That's what I'm going to talk to you about today. And I'm talking to you specifically in relation to systematic reviews of intervention effectiveness. So these are kind of synonymous with the Cochrane reviews from the Cochrane Library, and reviews which are asking questions which are along this line or have these kind of objective to assess the effects of an intervention or a comparison for a particular health problem. And then that might be in a specific type of people, disease, or problem setting. So here's an example of a Cochrane review title that myself and I've seen Leslie's joined did, information provision for stroke survivors and their carers. So systematic reviews often usually set out this acronym PICO for population intervention, the comparator that they're going to include, and importantly, the outcomes that they're interested in. And they are often also limited to particular study designs, often just randomized controlled trials, or maybe also some quasi-experimental designs. They may also be limited in terms of a particular setting or time frame, for example. And as I said, systematic reviews and these systematic reviews of intervention effectiveness, they will often produce a meta-analysis. There are systematic reviews without meta-analysis, but I think at least for understanding grade, it's helpful to consider them in relation to meta-analysis as a starting point. And just to make sure that everyone kind of has an understanding of the basics of what a meta-analysis is doing, they're often displayed in a forest plot like this. And we've got here the results from a number of studies which have estimated the same effect. So this is a comparative effect between, here we've got active information provision as one type of intervention and control on the other side. So this might be a usual care condition. We've got a point estimate, and we've got a confidence interval for each study. And we've got a pooled estimate here. This vertical line is the line of no effect. And when you're looking at forest plots, it's worth checking which way round. So this particular forest plot is for depression as an outcome. And over on this side, we've got favouring active information provision, and over on this side, control. But for different outcomes, those will be reversed. So worth working out which way is positive and which way is negative. You'll also tend to have a lot of numbers. So in this case, the number of people who were depressed and the number of people who were in each arm. The weighting, so this is how much each study's estimate contributes to this overall pooled estimate, and the pooled estimate there. So that's just this this final column is essentially the same as what we've got visually represented in the forest plot. And we'll also usually have some statistics around heterogeneity. So that's how different the study estimates are from one another, and how much that might be down to chance or due to differences between the studies, and a test for the overall effect. So that's how likely the pooled estimate is to differ from no effect. I'll just show you a slightly different example of a forest plot. So these are basically the same kinds of things in a slightly different order. But I wanted to show you this example because here in the forest plot, you can see that there's quite a lot of heterogeneity. There seems to be a group of studies which are looking at, which seem to be estimating somewhere around no effect, and a group here which seems to be having a large estimate. You'll see also that in this case, the outcome's the other way around. So the positive, the intervention, favouring the intervention is on this side. This is for a different kind of outcome, but it was just to show you how you can kind of visually see the heterogeneity here. So another common thing that we do in systematic reviews is to assess risk of bias. And when we talk about risk of bias, we're talking about systematic errors and systematic errors in the conduct of or systematic errors in the result that have arisen due to the conduct of the study or the analysis or the reporting of it. And it's worth saying that it's not talking about quality in general, and that very high quality studies can still be at risk of bias for a variety of reasons. You might be familiar, if you've looked through systematic reviews before, with this kind of graph or diagram where we've got a number of studies down the left-hand side, and they've been assessed for risk of bias in a number of domains, and perhaps overall as well as here. And yeah, either judged as low risk, which are the green pluses here, some concerns in older versions of risk of bias assessment that might be unclear risk of bias, or as high risk of bias, this red X. So we're talking about internal validity when we're talking about risk of bias. And this is bias, and as I said, this is judged in various domains typically. These are the domains that you have within the latest version of Cochrane's tool for assessing risk of bias, which is called ROB2. So bias due to randomization. So are the groups truly randomly allocated? Bias due to deviations from the intended interventions. So is the difference between the group due to other interventions than the ones that we were intending to assess. Bias due to missing outcome data. So, for example, if a number of people have been their outcomes have been lost from one group, perhaps because they didn't like the intervention, then that's likely to bias your outcomes because they may be systematically different in other ways. Bias in measurement of the outcome. So, for example, was the outcome a matter of judgment, and did the person who was making that judgment know which group the person was in, and therefore might they have come to a different decision than they might have otherwise? And bias in selection of the reported results. So if there were 5 different ways you could report this outcome, and you've chosen to report the most interesting looking of those findings, then that's clearly another example of where bias could creep in. Okay, so that's a kind of a very brief skip through systematic reviews with meta-analysis, just to hopefully orientate people, those who aren't already particularly familiar with those. But what does that have to do with grade? So as I said at the start, often people present those meta-analyses and the results of those, that pooled estimate, the diamond at the bottom, and they often assess risk of bias, but they don't necessarily pull those together or consider other factors that might make us less certain about the evidence, and come up with a kind of overall conclusion. So GRADE stands for Grading of Recommendations, Assessment, Development and Evaluation. And it's a framework both for summarising evidence, which is the bit that I'm going to be talking about today, and making clinical practice recommendations. So it has a whole other section which is about developing guidelines, which I'm not going to be talking about, but just for you to be aware that that's there as well. And so within a systematic review, we can use it to describe the degree of confidence or the certainty that we've got in each of our estimates of effect, each of those kind of estimates that were in the diamond, if you've done a system, if you've done a meta-analysis, or if the systematic review you're reading is presenting a meta-analysis. So we rate evidence within GRADE at 1 of 4 levels: high, moderate, low, or very low. So it splits it out into quite broad categories, and obviously in reality this is a continuum, but it allows us to kind of get some handle on the overall evidence. These symbols get used, so 4 of these pluses for high, and then going down to just the 1 plus for very low. And these different definitions, so ranging from we are very confident that the true effect lies close to that of the estimate of effect. In other words, the estimate is pretty much the true effect from everything that we can see, down to very low. We've very little confidence in the effect estimate. The true effect is likely to be substantially different from the estimate of effect. So we've produced an effect estimate, but we don't think that it has very much to do with the true effect. One of the key outputs from GRADE is, from the GRADE processes, a summary of findings table, such as this. And what this does for a typical systematic review with pairwise meta-analysis is to present in a table for one kind of comparison, so one type of intervention against the other. We've got a number of different outcomes down the left-hand side here. And there's a number of summary statistics here, but we've got the certainty of the evidence, and then an interpretation of the evidence over here. And as we go through, we'll kind of build towards working out what that interpretation might be. Now, I'm quite a visual person. I would like it if these summary of findings tables were a bit more graphical, but this is what they look like, and they're still useful tools once you get to know your way around them. This is a kind of a pictorial representation, which I've closely borrowed from grade. So this is intended to illustrate the kind of the overall process of grade. The top green box is the evidence synthesis part, the systematic review part, which we're going to be talking about today, and there's that bottom box, which is about the kind of guideline recommendations element, which I'm not going to be talking about. So we've got our PICO or PICOS with the study design as our criteria. We're going to choose critical and important outcomes to summarize. We'll extract data from all the different studies that we've identified through our systematic review onto our data extraction sheet. We'll produce a meta-analysis based on that data, and we will judge risk of bias in those results. And then through that, we'll develop our certainty estimate, our grade estimate, and our summary of findings table. And then it would go through this recommendation phase if you were developing a guideline. So one of the key things that they emphasize within grade is the importance of identifying what are critical and important outcomes. And if you're reading a systematic review, it's worth asking yourself the question, are the outcomes that they're looking at critical or important outcomes, or are they unimportant outcomes? Are they trivial outcomes? Sometimes reviews will be looking at the things which have been measured, but they might have only fairly limited importance in terms of clinical decision making. And if you were conducting a systematic review, you'd want to have stakeholder involvement to help identify what these critical and important outcomes should be. And you should be considering not just the beneficial outcomes, but also are there any adverse outcomes that you should be looking out for and including in your review. So, as I say, the focus of grade in this talk is rating the quality of the evidence, and the approach that's taken in grade begins with the study design. And if you've included, or if the systematic review you're reading has only included randomized trials, you start with a high rating, and you can then work down from there by rating down when there's serious problems or very serious problems with one of these items. And we'll go through each of these in more detail, but so study limitations, which is basically risk of bias, which we talked about earlier. Inconsistency in the results of the individual studies that have contributed, which is heterogeneity, as we saw earlier. Indirectness in the evidence. So some of this will be more applicable to you as a reader of a systematic review than as an author. But this is about rather than that internal validity, it's the external validity. How closely does the review evidence match the situation that it's trying to be applied to? And in precision, so this is about the pooled estimate and how precise it is, so the confidence intervals around it, but also the sample size that's contributed to it. And finally, publication bias, which is about the decision to not publish results from a particular outcome, or not to publish the results of a particular study, or maybe not the decision by the authors, but maybe decision by journals not to carry a publication based on the results that have been reported. So, as I said, if it's a randomized trial, or even if it's a quasi-randomized trial, we'll start at high quality. If they're observational studies, you would start at a low quality, and in that case, you can also rate up as well as rate down for these different reasons: a large magnitude of effect, a dose response gradient, or if the evidence is contrary to plausible confounding. Excuse me. Okay, so the first domain of grade that we're going to look at again is study limitations. So back to risk of bias. And for the we're interested here in the studies that have contributed to a particular result, a particular finding, rather than all of the studies that are within the review. And in the latest version of the Cochrane risk of bias tool, you're not actually assessing risk of bias in the study, you're assessing it in the specific result. So it may, the risk of bias may vary by result for the same study. So it's kind of more apparent when you're doing it that way. But so for if we've done a meta-analysis which included these studies, we might have a traffic light plot like this. If we only had evidence that was coming from results that were mainly low risk or some concerns, then we wouldn't downgrade. So if there was maybe just one of these studies was high risk, we wouldn't downgrade. Another way of avoiding downgrading the evidence due to risk of bias would be if we were to do a sensitivity analysis. So if we were to look at the estimates, if we were to just include the studies that were low risk or some concerns, and compare that to our estimate when we're also including the high risk studies, if there's no substantial difference, then we might decide that any risk of bias isn't actually playing out in terms of our estimate, so we don't need to downgrade. If we find that most of the evidence is within one domain is high risk, so as in here or here or here, then we would have serious concerns. And if most of the evidence in more than one domain is high risk, or if there's a critical problem in one domain, then we would have very serious concerns. So here we have a number of studies which are at high risk of bias. So my kind of starting assumption would be that we have serious concerns, because in general these ones which are high risk of bias come from one domain only. But we need to consider a number of other things. We need to consider the study weight. So it might be that these studies which are at high risk of bias are the largest studies in our meta-analysis, and the other studies are relatively small. That might mean that the major contribution, or maybe particularly this Lewin one with two domains at high risk of bias, is making the main contribution. So there might be reasons why we would want to downgrade to very serious concerns. Perhaps we have critical concerns about the problems that are contributing to these being overall high risk of bias. On the other hand, it might be the other way around. So it might be that the larger studies are the ones for which we have less concern, only some concerns, and that the studies that are at high risk of bias are contributing relatively little to the meta-analysis, and therefore what the pooled estimate is. So we might then decide that we don't need to downgrade. So the next domain that we consider is inconsistency of the results. So heterogeneity, which we looked at briefly before. Now, although there are statistical measures of heterogeneity, looking at heterogeneity within grade is not just about looking at those statistical measures. The first thing you should be doing is eyeballing the forest plot. So looking at the overlap of the confidence intervals, and looking at this forest plot, we can see that in general the confidence intervals are overlapping one another. However, there's this estimate which is over to one side, and almost it does just slightly overlap this other confidence interval, but barely. So that's a concern for us, that these are perhaps estimating quite different effects from one another. But another consideration is whether the heterogeneity is qualitative or quantitative. So whether the differences between the studies are, so to give an example of qualitative, some of the studies are estimating harm and some of the studies are estimating benefit, or whether it's about the difference between, say, a large effect and a very large effect, but both in the same direction. And we would tend to have more concern about differences that are a qualitative effect, because that makes us less certain about whether it's causing benefit or harm, whereas whether the estimate is of a large or very large effect is perhaps of less concern to us. It's still either clearly beneficial or clearly harmful. And you can also use those statistical measures. So like for this forest plot, for this meta-analysis, the I-squared was 49%. So that would tend to tell us that there was probably substantial heterogeneity. So here we would rate this as serious concerns because of this lack of overlap in the confidence intervals between these two, and because we're relatively close to the line of no effect here. If all of this was shifted so that it was over here, or in other words, if the line of effect was over here, line of no effect was over here, then we might decide not to downgrade. And to come back to the example I showed you previously, again, we've got considerable heterogeneity here, and in this case, we've got confidence intervals which completely don't overlap. These three don't overlap at all with this one, and pretty much these four only barely overlap with these two and this bottom one. And we seem to have a kind of qualitative difference between some estimate of no effect and some estimate of a large difference. A number of the point estimates also, if we look in relation to the pooled estimate, many of the point estimates sit outside of the pooled estimate confidence intervals, and even the confidence intervals of the individual estimates are kind of not overlapping the center. So we would certainly have serious concerns, and we might have very serious concerns here. So the indirectness of the evidence is the next consideration within grade. So how applicable were the studies that were included to the population of interest? Were the interventions the ones which were specified, and what was the setting in which they were in which the studies were conducted? So you might think about whether these were particularly experimental studies with highly selected populations, perhaps with kind of world-leading experts delivering the intervention, or in a particularly outstanding setting, or were these very pragmatic effectiveness trials? How relevant to the outcomes? For example, were the outcomes measured just shortly after the intervention ended, after just a few weeks, or were they measured a year or 2 years later? Now, whether that's important will depend on your particular question, but it often would be, you'd often be more interested in those long-term outcomes. And it might be that the outcomes that have been measured are really surrogates or proxies for an outcome of interest. So you might have looked at bone density instead of fractures, for example. So again, that would be a reason to downgrade if you were wanting to apply that result in terms of fractures, then you would want to downgrade there. And also the systematic review might have looked at evidence of it might have gathered evidence on two different kinds of intervention. one again, but in both cases, the studies that have been included have only compared the intervention to, let's say, usual care or no intervention, and they haven't been directly compared with each other. So you've got two results, which are a comparison with no intervention, and then you're trying to make an inference on the basis of those two pieces of indirect evidence. So again, a reason to be less certain about the result. So imprecision within grade is about imprecision in the pooled estimate, and so it might sound as if this is about the width of confidence of a confidence interval, how precise it is. But again, as with when we were talking about heterogeneity and whether we were estimating benefit or harm, what we're particularly interested with imprecision is the confidence intervals in relation to benefit, harm, or no effect. So I've got this diagram which I've taken from this paper. We've got our black line, our line of no effect. These lines are not the individual study estimates. This is a representation of the pooled estimate, so often shown as a diamond, but here is a straight line. And what's been drawn on here, this grey box, is an assumed kind of area of little to no effect, or a trivial effect. So an effect which is so small that we consider it unimportant. And what that is for a particular outcome can often be very difficult to decide and to work out, and I'll talk a little bit more about that in due course. But if we can accept the idea that there will be some effects which are so small that we consider them to be trivial, that's what this grey box represents. And then depending on where the confidence interval lies for a point estimate, that will depend how we judge the imprecision. So if the point estimate lies within that area of little to no difference, the trivial difference, if one or both ends of the confidence interval lie outside that, in other words, they include either substantial harm or substantial benefit, you downgrade once or twice. So if this was a bit of a smaller confidence interval, and so it stuck out here, and we were the confidence interval included benefit but didn't include substantial harm, we would downgrade once. For this, we would downgrade twice. And this example here, the confidence interval is entirely within the area of little to no difference, and so we don't downgrade at all for imprecision. If the point estimate lies outside of this, so we're either estimating a beneficial effect or a harmful effect as our point estimate, if our confidence interval crosses the line of no effect, then we downgrade once. So in this example, we downgrade once. Here, the confidence interval doesn't cross the line of no effect. So although it comes into the trivial effect end, we don't downgrade once. And if this was a wider confidence interval, and so it extended all the way out into harm, then we would downgrade twice. So the same as for the trivial difference. If the confidence interval includes both benefit and harm, we downgrade twice. This is interesting because it allows us to talk about results which are not statistically significant. So the confidence interval extends beyond the line of no effect or even into harm, but it allows us to talk about the point estimate with some degree of certainty, perhaps, depending on the other reasons that we might have wanted to downgrade. So we're not just we're not solely working on that p-value. The other thing that we have to consider with imprecision is what's referred to as the optimal information size. So as well as the confidence intervals, we want to consider how much information, how much data has contributed to that estimate. If we've got relatively small sample sizes, then the confidence intervals can be fragile, and with just a few additions, the confidence intervals can change quite dramatically. So this is effectively asking whether the analysis is sufficiently powered. So it's as if you've had done a trial and done a sample size calculation, and putting together the different studies, whether you've got sufficient sample size, as if you'd done it all as one study. If you've not, if there's insufficient data there, then you would downgrade. Okay, and finally, the final consideration is publication bias or non-reporting bias. So this is about selective reporting of results for particular outcomes based on the size, p-value, or the direction of the result. It's quite hard to detect, and it shouldn't be assumed. We tend to use what are called funnel plots to look at this. So this is an example of an imbalanced funnel plot. If it was balanced, we would expect to see other dots around here on this side. It's worth saying that there can be a couple of things. Without enough studies, it's very difficult to detect it. And as I said, we shouldn't assume it. But also, there can be other reasons for imbalanced funnel plots. So a funnel plot is looking at the sample size on this side and the effect estimate on this side. So the idea is that the larger studies would estimate more consistently, and the smaller studies would estimate more inconsistently. So you get a spread of their point estimates, and you end up with this funnel shape. But it might be that there are other reasons why small studies end up with larger estimates or smaller estimates than the big studies. It might be that these were performed by experts. It might be that there was a change in usual practice as a result of early publications. So it's not necessarily down to publication bias and worth considering, because you might have already downgraded for another reason if it was one of those others. There's also this tool which I've not had a chance to use, but the preliminary risk of bias due to missing evidence, the RobMe tool, which is in development at the moment. So putting together all of those different domains, we come out with our evidence rating. Although I've kind of described it as downgrade or don't downgrade, or maybe downgrade by 2 on each domain, the authors of grade emphasize that you should be considering the balance between the different domains and an overall judgment. So if you've got a number of borderline decisions, you might decide to downgrade for some of them and not downgrade for the others, and consider it in relation to this this overall judgment that we looked at the start, and the definitions of them. And so then based on that, that will help you to populate this column of a summary of findings table, or if you're reading a systematic review that's used grade, you should find that certainty estimate there. And crucially, because as I hope become clear over the course of the presentation, these are really judgments that you're making. There should be explanations, footnotes for the table, explaining why the authors have come to a particular judgment. And you as a reader may want to disagree, or it may be that your setting is different, and therefore you would come to a different judgment if you were wanting to apply this evidence to your setting. And then there's also the interpretations, which we'll come to next. So there's been work done on developing these plain language statements, which can be made on the basis of grade, and these really hinge on 2 things: the certainty estimate. So was it high, moderate, low, or very low? In which case you use these different phrasings. So if it's high, then the intervention results in, or if it's moderate, it probably results. Low certainty, it may result, or very low certainty, just the evidence is very uncertain, as we've got here. But we can also look at the effect size. And so if the effect was trivial, then we talk about there being little to no difference. But we can also talk about there being a slight change, a change, so unqualified for a moderate effect size, or a large change. And so putting those together, you end up with statements such as these. So I'll just talk quickly about this to leave some time for questions. But as I mentioned, in relation to imprecision, we might want to talk about the effect size.
Speaking.
And this can be difficult to estimate. It's I think particularly important to consider this for surrogate outcomes, and you might have a much larger effect that you would consider trivial before you began to consider the outcome to be important. There are various ways of trying to work this out, which I think all have their different problems about them. but the language that's used is around minimal clinically important difference, often. So that's about selecting what's important versus trivial, but then we also are interested in what's small, moderate, or large. If it's a continuous scale that you're looking at, there are a number of rules of thumb for working with, such as these for a standardized mean difference. If you're looking at a binary outcome, it's worth converting from, so a meta-analysis will often be done in terms of an odds ratio or a risk ratio, but it's often worth converting that into an absolute difference. So numbers needed to treat, or a number of patients per thousand, a difference per thousand, a risk difference, to get a sense of how important or otherwise it is for your particular outcome. And then obviously, depending on what the outcome is, will vary vary kind of how many per thousand would be important. Okay, so grade is an approach that you can use to rate the certainty of evidence in systematic reviews, particularly those with meta-analysis, by considering study limitations, inconsistency of the results, whether the evidence is indirect, how precise the estimate is, and what the risk is of publication bias. And you end up with a rating of high, moderate, low, or very low. And if you think of those in terms of those plain language statements of it results, it probably or likely results, it may result, or it's very uncertain, then I think that's a useful way of kind of interpreting the output from a systematic review. Okay, so thank you very much. I hope that was clear. I'm stopping sharing, hopefully.
That's great, Tom. Thank you. I think
My
you have
pleasure.
got a question in the chat. And if anyone's got any other questions, you can put them in the chat or just put your hand up. Leslie's asked, is the grade process managed within the same software as the review if doing a Cochrane review?
It's not, or at least last time I did a Cochrane review, it wasn't. So there's some separate software called Grade Pro, which is a web application which you can use to manage the ratings. You don't necessarily have to do it within software. You can do it in a paper-based way, or within spreadsheets if that's the way you like to work. But there is a web app called Grade Pro to do it.
Fabulous. And Leslie's also suggested if you can return in a few months' time to talk about using grade to make guideline recommendations.
Well, if I knew about it, then I would gladly do so. It's not something I've done. So
we'll park that one for now then.
Yeah, thank you.
Lovely. Has anyone got any more questions for Tom? While you're all thinking about your question, Katie's just put thank you. It was really, really helpful. So that's fantastic. Good. I just want to let everyone know that we're recording this and it will go on our YouTube channel by the end of the week, and I will send the link round to everybody. And Tom said he was happy to share his slides as well, so we'll send those round. And I've also put the links to all our website, YouTube channel, newsletter in there. So if you sign up to our Yorkshire Humber newsletter, we put all our lunch and learns and our recordings in there as well. Lovely. So let's have a look. I don't think there's any more questions. Last minute opportunity for everybody if you've got any. That's fantastic. Well, thank you very much, Tom.
My pleasure. Thank you. Thanks for turning up, and thank you for hosting me.